Hi class, in this recording we're going to talk about senescence of the respiratory system and a lot of disease states of the respiratory system. To review, senescence is the loss of function as we age. So as we get older, we have decreased pulmonary ventilation because our costal cartilage, or the cartilage of the ribs, becomes less flexible. Our lungs also are going to have less elastic tissue in them and fewer alveoli as a whole, functional alveoli. As we look at elderly individuals, these elderly individuals are also going to be less able to clear the lungs of irritants and pathogens because of that declining pulmonary ventilation rate. And because of that, they're going to be more susceptible to respiratory infection. Another reason why they're less able to clear the lung of irritants and pathogens is because their mucociliary escalator slows down and they have fewer cilia, fewer functional cilia to move the mucus out of the lungs. And that mucus, instead of moving out of the lungs, tends to build up and be a site of bacterial growth, which can lead to pneumonia, an infection of the lungs. And it's worth emphasizing that in terms of infectious diseases, in America, pneumonia causes more death than anything else. We also could have COPD, chronic obstructive pulmonary diseases. And these are things, if we just look at the name, it's something in the lungs that obstructs or blocks the airways for a very long period of time, chronically. Emphysema and chronic bronchitis are two common examples of COPD. And it takes a lifetime of degenerative change for this COPD to set in. This isn't something that happens rapidly. It happens slowly over the course of a lifetime, this loss of function. COPD can contribute to hypoxemia, low blood oxygen, and hypoxic degeneration of the other organ systems. So not only do we have low blood oxygen, but that low blood oxygen causes other organ systems to begin to shut down. This causes an acceleration of senescence of the other body systems. So as we look at hypoxia, that's going to be a deficiency of oxygen within a tissue or the tissue's inability to use the oxygen so we can officially define that term. And hypoxemic hypoxemia is low blood oxygen causing low oxygen in the tissues. So if we don't have enough gas exchange in the lungs, if we have inadequate gas exchange in the lungs, we have low blood oxygen causing low tissue oxygen. This also can happen if we're at high elevations, or if there's impaired ventilation, if somebody's drowning, obviously, or if they're choking. Aspiration of a foreign body is technical jargon for choking on something. So if you're drowning or choking, obviously you're not going to get enough oxygen into your bloodstream. Respiratory arrest or degenerative lung diseases can also contribute to hypoxic hypoxia. We also can have ischemic hypoxia. So unlike hypoxic hypoxemia, ischemic hypoxia is due to inadequate circulation of the blood. So this can be congestive heart failure or a blockage of the blood vessels directly. So there are different ways we can have low oxygen to the tissues. We can have it due to not enough gas exchange in the lungs or not enough perfusion or blood flow through the lungs. If somebody has hypoxemia, a lot of times the tips of the distal organs, so fingertips, toes, ears, lips, become blue. This is blue skin is cyanosis, and that's review from last class, but I just want to emphasize that again. If we have anemic hypoxia, that is going to be hypoxia due to the inability of the blood to carry oxygen, so typically low blood hemoglobin concentrations. If we have histotoxic hypoxemia, this is because we have some kind of poison in the blood preventing the tissue from carrying oxygen. Cyanide poisoning needs to be some kind of poison in the tissues preventing the tissues from using oxygen. So cyanide poisoning is the classic example of that. And there's some other more esoteric poisons, but cyanide is by far the most commonly talked about one. Now, just because your skin is blue does not mean you have cyanosis, or excuse me, does not mean you have hypoxia. You might have blue skin like Paul Karasan did because you're ingesting too much colloidal silver. So if you have bright blue skin, like Paul does, it may be because you're ingesting excessive amounts of silver, not necessarily because you have low blood oxygen concentrations. And for the record, ingesting colloidal silver does not improve your overall health outcomes, but it can make you look like Papa Smurf. Some oxygen imbalances that occur in our body can happen when oxygen concentrations are off. We, generally speaking, don't want to breathe 100% oxygen at 1 atmosphere. It's technically safe to breathe, but oxygen is kind of poisonous. Too much or too little is bad for you. In particular, we can have oxygen toxicity develop if somebody breathes in pure oxygen for at 2.5 atmospheres of pressure or greater for a short period of time, or 100% oxygen at 1 atmosphere of pressure for several hours or half a day continuously. If you have too much oxygen going in, you're going to produce too many free radicals, such as superoxide or peroxides. Here's hydrogen peroxide as a common free radical. And as we have too many free radicals being generated in our bodies, those will destroy the enzymes that we use to regulate our metabolism and will also destroy the nervous tissue directly, ultimately leading to a breakdown of our organ systems. So if somebody has a loss of function in their eyes, if they're seizing, if their muscles are twitching uncontrollably, or they have jerky respiratory rhythms, lots of pain, coughing, shortness of breath, acute respiratory distress syndrome, these are all signs that somebody's been exposed to too much oxygen. Now, one of these by themselves probably isn't going to be a symptom of oxygen toxicity, but it's the entire presentation. If you see somebody that has most of these symptoms, then you have to wonder, do they have oxygen poisoning? We used to treat premature infants with hyperbaric oxygen chambers. So we would put them in a chamber with elevated concentrations and pressures of oxygen, but it's been found that that causes more harm than good, and that therapy has been abandoned for alternative ways to help oxygenate those individuals' bloodstreams. As we look at COPD, this is a very long-term obstruction to the airflow in the lungs that reduces pulmonary ventilation. Chronic forms of COPD, and this is a little bit of a review right here, I know I'm being a little redundant, include chronic bronchitis and emphysema. These chronic bronchitises or emphysemas are almost always going to be associated with smoking. When my wife was doing her internships, 100%, or say clinical placements, 100% of the patients she worked with that had either of these diseases were smokers. Other things that can increase the risk of COPD include air pollution, if you have exposure to airborne irritants at your job, or if you have bad genetics. You may also have an elevated risk of COPD. We also could have chronic bronchitis, chronic inflammation of the bronchi within that lower respiratory tract. And if we have chronic inflammation of the bronchi, the goblet cells are going to enlarge and produce excessive amounts of mucus. And then that excessive amount of mucus is going to partially immobilize the cilia, which then fail to remove that mucus. The thick stagnant mucus builds up, and it's an ideal medium for bacterial growth. So chronic bronchitis will almost always lead to pneumonia. People that smoke are going to compromise their alveolar macrophage function, so their alveolar macrophages will not be able to remove debris from the alveoli as effectively, and they start to cough a lot. And that constant coughing will bring up thick yellow mucus, known as sputum. It's thick mucus plus cellular debris from their lungs. And symptoms of this chronic bronchitis include hypoxia and cyanosis. So they'll have low blood oxygen and a bluing of the the distal tissues of their bodies. When somebody has emphysema, the walls of their alveola break down. So as we look at the alveolar sac, instead of having separate individual alveola, the alveola will merge together. So we have enlarged, engorged alveola within the alveolar sac. And that's going to make it so there's fewer air spaces that are larger in volume, which ultimately reduces the surface area of the respiratory membrane. And if we reduce the surface area, we'll have less gas exchange. The lungs also have a lot of scar tissue buildup, making them less elastic. And if the lungs are less elastic, the patient has to actively exhale more, has to force air out of their lungs. The lungs themselves are going to become flabby as opposed to springing back to their original position, and they'll have these little cavities built up. And these cavities in this figure are dark black because of congealed blood that's within them. But these cavities are associated with the breakdown of the alveolar walls. Air passageways are also going to start to collapse within the lungs with the loss of the elastic tissue, which will obstruct airflow and trap air in the lungs. So somebody who has emphysema has a very hard time exhaling because air becomes trapped in their lungs, and they develop a barrel-chested appearance. So these individuals, they breathe in and out very shallowly, while their chests are expanded. They also, because of this condition, are going to weaken the thoracic muscles because they have to work so hard to exhale. And the thoracic muscles aren't designed to be constantly worked like that. Those internal intercostals aren't designed to handle that much work. So as we look at COPD, COPD is also going to reduce vital capacity, so the amount that the person can breathe, inhale and exhale. COPD is also going to be linked to low blood oxygen, high blood carbon dioxide, and elevated acid levels, or a lowering of the pH in the bloodstream, or respiratory acidosis. When the person has that low blood oxygen, hypoxia, that's going to stimulate erythropoietin release from the kidneys. And as they have more erythropoietin release from the kidneys, they'll make more red blood cells in the red bone marrow, causing them to have an elevated red blood cell concentration, or polycythemia. Somebody may also develop what is known as cor pulmonale. Cor pulmonale is a condition when we have hypertrophy of the right ventricle of the heart. And this hypertrophy of the right ventricle of the heart corresponds to an obstruction of pulmonary circulation. So the amount of blood entering the lungs is less than the amount of blood exiting the lungs. And as we have fluid buildup in the lungs, that fluid that builds up in the lungs will go hand in hand with the right side of the heart, the right ventricle of the heart, having to work really, really hard to push fluid through that obstruction of the pulmonary circulation. Another problem with our lungs as we age is lung cancer. Lung cancer has been very, very well correlated with smoking tobacco cigarette. We haven't definitively established causality because those are highly unethical experiments that will never be approved, but the correlation is so overwhelming that everyone just accepts that smoking cigarette smoke is associated with an increase in lung cancer. What many individuals are not aware of yet, though, is that marijuana smoke also contains high concentrations of carcinogens, just like tobacco smoke. So here is an article that I hyperlinked from NCBI. You can click on the link to read the article yourself. Here's a table I pulled from the linked article, evidence of carcinogenity in marijuana smoke. And since more and more people are deciding that it's okay to smoke marijuana, it's important for you as future healthcare providers to be able to give data-based advice to these individuals. So if we look at the concentration of that chemical in marijuana versus the concentration of that chemical in tobacco, we find that for these chemicals like acetamide, there's very low levels, not quantified. But other chemicals like arsenic in marijuana smoke are at 0.002 micrograms per cigarette, marijuana cigarette, or micrograms per joint, whereas with tobacco smoke, we're looking at 0.005 micrograms per joint. When we look at benzene, we have 58 micrograms of benzene per joint of marijuana versus 62 micrograms of benzene per cigarette. And we could go down the line. I'm not going to read all these out loud for you, but I just want to highlight for you the fact that marijuana smoke contains high concentrations of well-established carcinogens, just like tobacco smoke does. Sometimes tobacco smoke contains more. Actually, most of the time, tobacco smoke contains more, but occasionally you'll find instances where marijuana smoke contains higher concentrations. For instance, if we look at 1,3-butadiene, or if we look at quinoline. Excuse me, not quinoline, pyridine. Those are some instances where marijuana smoke will contain higher concentrations of the carcinogen than tobacco smoke. So in summary, if you smoke tobacco or marijuana, you're more likely to get lung cancer. Speaking of lung cancer, there are some kinds of lung cancer we need to talk about. The most common kind of lung cancer is squamous cell carcinoma that begins with the type 1 that begins with the transition of the squamous cells of the bronchial epithelium. And those squamous cells are going to be made from a stratified squamous. So this squamous cell carcinoma will directly come from a stratified squamous epithelium. That stratified squamous epithelium forms from the transformation of the ciliated pseudostratified columnar epithelium. So as an individual smokes, the mucocilia escalator breaks down, and the ciliated pseudostratified epithelium converts to a stratified squamous epithelium. And if they continue to smoke, that stratified squamous epithelium is likely to turn into a squamous cell carcinoma. Those squamous cells then invade the bronchial wall, causing lots of bleeding lesions in the patients. If we look at the histology and take a biopsy from a patient, you see these swirls of keratinized squamous epithelium replacing normal functional respiratory tissue. That's what the squamous cell carcinoma will look like in a photomicrograph, or histologically speaking. We also can have an adenocarcinoma. As we look at adenocarcinomas, those are going to originate with the goblet cells, or the mucus glands within the lamina propria of the lungs. And this is what histologically they look like. And we also can have small cell, also known as oat cell carcinoma. This is the least common kind of lung cancer and the most dangerous kind of lung cancer. So if you were to look at somebody who has this carcinoma, if you were to look at that histologically speaking, it looks like a bunch of oatmeal, purple oatmeal flakes under a microscope. And it's named for those clusters of cells that resemble the oat grains. Small cell carcinomas, or oat cell carcinomas, typically are going to originate in primary bronchi, and because they originate within the primary bronchi that supply air to the entire left lung or entire left lung, it can invade the mediastinum cavity very rapidly and travel to other organs very rapidly. That's all we have for this recording. If you have any questions or comments, please feel free to post them in the class discussion board or to shoot me an email. And as always, happy studies.